Welcome to Coffee with Kyle number 8. I'm Kyle Ridgway. Good morning. So today I wanted to talk a little bit about the dichotomy I see between patient-centered care and outcomes-based repayment or value-based payment in healthcare. And the example that I wanted to use that I've thought about before, and disclaimer, obviously I'm not a cardiologist, so I will get some of the details here wrong to all my cardiology friends. But I think it's an apt example. So the example is heart failure. So it's been fairly well researched at this point, to my understanding, that in heart failure, the best evidence-based treatment is to get someone on a beta blocker, sometimes an ACE inhibitor, and sometimes a low-dose diuretic. Pretty simple. If we're in an outcomes-based or value-based or evidence-based assessed payment model, it's quite obvious what you need to do. You need to diagnose patients with heart failure accurately, and you need to get them on an evidence-based beta blocker as soon as possible, and then consider the addition of an ACE inhibitor and a diuretic as indicated by their clinical picture or exam findings or test findings. Seems pretty simple. But if we think about patient-centered care and we think about individualizing treatment, not just to a patient's physiology and presentation, but also to their goals and desires, there could be a bit of a tension here. And I'll give this example. One of the side effects of being on a beta blocker, because of the way it works and the physiologic mechanisms and the slowed heart rate, is fatigue, potentially dizziness, and in males you could actually be impotent. Okay. Well, what's the risk of not taking it? Well, one of the risks of not taking it is that you can die sooner, you're hospitalized more often, and you can have more symptoms of heart failure, shortness of breath, things of that nature. So how would we parse this problem? Well, if we think about a shared decision-making model and we think about actually elucidating what's important to the individual, both at a symptom relief level, but also logistically. Is this a patient who does or does not want to be in the hospital? Is this a patient whose sexual life is very important to them? These are all important questions to consider. But then we still need to do good diagnostic processing and good interaction with the patient to elucidate what's the best treatment or evidence generally for the condition they have, and what's the best treatment plan for this patient's presentation individually. But then we can talk about what the effects are of treatment, both physiologically, symptom-wise, mortality, morbidity, hospitalizations, and other such outcomes that may be important to the patient. But then secondarily, we parse down into what are the side effects of the treatments on all those same levels, physiologically, symptom-wise, morbidity, mortality, and hospitalizations. Now, maybe the patient decides, you know what, I do not like the side effects of a beta blocker. I'm informed on what the risks are of not taking them, and I do not want to take them. So they make that decision. That's an individualized decision that their physician or healthcare provider helped them through to come to. And most would say that's a good decision for that individual. Now, the caveat here is fully informed decision making means that we actually assessed the patient's understanding and ability to understand, but that we also tried to understand them as a person so that we could elucidate their goals, but also so we could elucidate their expectations, their desires, and their hopes. Because I think sometimes what happens is we say, well, we educated this person, they just don't get it. And that's true. There are some people who it's hard to get through to. It's hard to change their understanding or behavior, which I've talked about previously. Maybe they have very low health literacy or very low education level. We're not experts in education, unfortunately, so those situations can be quite challenging. So in those cases, instead of giving up, we need to try to then better understand the individual so that we can help them make the best decision for themselves. Now, how do we account for this in an outcomes-based payment model or payment based on adherence to best practice? Now, if you think insurers can't see this, they can. I have a colleague at Pittsburgh, Chris Bice, who works with payers, and he can drill down to the provider level and see what your practice actually looks like. So the future is coming where insurance companies may actually penalize you or reward you for adhering to certain treatment regimens or billing certain codes or imparting certain treatment plans with specific patients. Now, one thing that we need to know is that payment absolutely drives practice. We have to accept that. But a situation where we pay only for outcomes or only for adherence to evidence-based practice is actually going to de-incentivize individual care. And there's kind of a pendulum here between fee-for-service, get paid for what you do, doesn't matter what it is, over to value-based, outcomes-based payment. And I think the pendulum is, rightfully so, swinging towards a value-based payment system. But my thought is that if that pendulum swings too far, we're going to miss out on some of the positive impact of taking a patient-centered approach. And so I think that we can't just take a one payment model approach. We have to have fee-for-service, accounting for individualized shared decision-making, as well as adherence to evidence-based practice guidelines and best practice. Now, one thing that I think is important to remember, while best practice may be best at the group overall average of care received level, it absolutely cannot be always the best at the individual level. And this is even as a mathematical concept that if you look at a bell curve and you look between two groups, the mean between two groups will tell you a lot about the groups, but it tells you nothing about the individuals from those groups that you may encounter because you don't know exactly where on the bell curve where they lie. So, rules exist to streamline performance by simplifying and guiding decision making, and I think that's helpful. Read the Checklist Manifesto if you want to dive deeper into that concept. But the true expert knows when an apparent exception should follow the rule, and also when a true exception exists. We all want the physician, the provider, the professional described earlier in this example. So how do we structure payment to incentivize and reward her? I think that is a very important question. And to bring it back to a physical therapy or rehabilitation example, I read the book Being Mortal by Atul Gawande, which is a fantastic read whether you're in healthcare or not. It applies to any human being. And one thing that really struck me was he interviewed a bunch of older folks who were either in retirement communities, nursing homes, had some semblance of physical or cognitive disability. And he also interviewed a lot of caregivers and family members. And what was not surprising is that family members and caregivers tend towards safety and putting patients in safe environments and safe care plans. So for example, older patient comes into the hospital, had a pretty low but successful functional baseline. They're doing okay, but we're afraid about falls. We're afraid about them functioning decently at home, so we recommend them going to subacute rehab or a skilled nursing facility. Well, what was interesting is that when he interviewed patients, when he actually interviewed the people whose lives these decisions affect, what they reported is that they would undertake a significant amount of risk to have the situation or the life experiences they wanted, which for most people was staying in the home environment. This ties to some research, some survey data that's actually been done that was quoted in the book, where patients will actually rate the possibility of going to a nursing home or a SNF as worse than death. This was a piece of information combined with that book that totally changed the way that I interface with patients and families when making discharge recommendations. So I think I'll leave you with that today on the dichotomy between outcomes-based payment and patient-centered care. It was good to see you. Have a great day.